આગળ રેઝિસ્ટન્સ ફર્સ્ટ યર.
તમે ક્યાંથી આવ્યા? ક્યાં તમે?
આઈ એમ ફ્રોમ મહેસાણા, નેટિવ ગુજરાતી.
મહેસાણાના પ્રજાપતિ જો પટેલ નથી. ના પટેલ તો અમેરિકામાં હોતે.
વિષ્ણુ પટેલ. વિષ્ણુ પટેલ. એમાં તેને કિંગ ફિઝિશિયન
એ મારો ક્લાસમેટ થાય વિષ્ણુ પટેલ.
આપણે તો એકવાર પ્રેઝન્ટ કરી લીધું, તમે તો બીજી વાર કરો.
ના સર, ફર્સ્ટ ટાઈમ. Today's topic is about STEMI equivalents. In brief, STEMI represents myocardial ischemia caused by complete occlusion of epicardial coronary artery into atherosclerotic plaque, rupture or subsequent thrombosis formation. STEMI criteria may develop to identify the patient in the population that benefit from emergent catheterized and revascularization. According to AHA guideline 2018, to diagnose STEMI greater than 2.5 mm ST elevation V2 to V3 in a male patient less than 40 years and greater than 2 mm ST elevation V2 to V3 in male patient greater than 40 years. Greater than 1.5 mm ST elevation V2 to V3 for females regardless of this. Greater than 1 mm ST elevation in all other limbs. So any new J point elevation from the previously normal ECG or greater than 1 mm is considered ischemic.
લેપટોપ થી કરना
ક્યાંથી ઓપરેટ
So J point is defined as junction between the termination QRS and ST segment concept. The ST segment should be measured against the isoelectric EP segment, which by assuming the it was as a baseline. Now STEMI equivalents represent coronary occlusion without meeting the any AHA criteria of significant traditional ST elevation criteria, and which are importantly recognized in a timely fashion. Emergency physician must know the involve the cardiologist in suggesting any ST elevation and STEMI equivalents patients. Management is same in both STEMI equivalents and STEMI patients, which is for emergency reperfusion. First is isolated posterior myocardial infarction. Posterior myocardial infarction accompanies 50 to 20% of the STEMI patient, usually occurring in association with the branches involving inferior or lateral. Now isolated posterior MI is less common. This is 5 to 10% of infarct, and the lack of any ST elevation means that the diagnosis is often missed. Now posterior access on inferior or lateral infarct, which implies much larger area of the infarct myocardial damage, with a high chances of morbidity and mortality, with associated left ventricular dysfunction and death. So always examine the closely evidence on posterior MI in any patient is lateral or inferior wall MI. Now we see diagnostic criteria for posterior wall MI. As posterior MI is not directly visualized by the standard 12-lead ECG, reciprocal changes of the STEMI can be seen in the anterior septalis in V1 to V3. The posterior MI is suggested by following changes: horizontal ST depression associated with tall and broad RS greater than 30 milliseconds, and upright TS and dominant RS with RS ratio greater than 1 in V2 leads. In patients present ischemic symptoms, horizontal ST depression in anterior septalis like we said in V1 to V3 should raise suspicion about posterior wall MI. Here we can see that there is a ST depression along with the T wave, upright T wave, and a prominent R wave with RS ratio greater than 1. The septal leads are directed from the anterior precordium toward the internal surface of the posterior myocardium. Because the posterior electrical activity is recorded from the anterior leads and the anterior side of the heart, and typically injury pattern ST elevation and Q wave becomes inverted. It's like a mirror image from the anterior lead. So the ST elevation becomes the ST depression, Q wave becomes the R wave, and T wave inverts and becomes the upper T wave. The progressive development of pathological R wave to posterior infarction has been said Q wave, equivalent, and mirrored the development of Q waves in the anterior septal STEMI patients. Here we can see the proper 12 disease. We can see the ST depression with upper T wave with prominent R wave, and if we can mirror the image, flip the ECG, we can see the proper ST elevation with T wave inverted with Q waves.
So in which lead you will see the reciprocal changes of posterior MI?
Anterior leads, V1 to V3. These are reciprocal changes, mirror images.
No, not like that.
Anterior leads.
What are the reciprocal changes?
In STEMI, the artery which are occluded, there is a elevation in the changes in the same artery, and on the opposite side of the purpose area there is ST depression present in the ECG. The reciprocal changes.
માનો કે LED ઇનો હોય 180 એટલે V1 to V6 માં elevation હોય.
Inferior.
Reciprocal કેમ આવે?
Inferior. Anterior હોય તો પછી inferior માં આવે.
Inferior માં.
Inferior.
તો posterior નું કઈ રીતે આમ ખબર પડે reciprocal changes છે કે નહીં?
My anterior lead માં એ was reciprocal changes.
So that is what we are describing.
Yes, sir. Now, next topic is ST elevation in AVR. Now, ST elevation in AVR, which coexist with multiple lead ST depression, indicates the subendocardial ischemia due to oxygen supply or demand mismatch. The clinical cause for AVR ST elevation include left main stenosis, proximal LED stenosis, severe repercussion disease, or also can be seen in hypoxic or hypotensive patient. For example, any shock or any post cardiac arrest resuscitation. Now, ST elevation in VR can also be seen in context of anterior STEMI and LED occlusion proximal to the first septal branch and causing infarction in basal septum. Such cases will have association of ST elevation in anterior septal leads and ST elevation in AVR. There are widespread horizontal ST depression, most prominently seen in 1, 2 and V4 to V6, with associated with ST elevation AVR greater than 1 mm, and ST elevation AVR which are greater than V1 in this type of patient. In context of the widespread ST depression and with associated symptom of the myocardial ischemia, ST elevation same as elevation AVR greater than 1 mm indicate proximal LED or LMC occlusion, AVR greater than V1 again, and absence of any ST elevation in AVR almost entirely exclude the significant LMC lesions. Here you see, we can see that multiple ST depressions associated positive AVR. Next is LBBB with Garbosa. Now LBB is what V1, there is a dominant SU, V6 broad, QRS most M type of RA. QRS duration greater than 120 milliseconds and with left axis deviation and poor progression of RA. Now in Garbosa criteria, in patient with left bundle backdrop or ventricular pace rhythm, infarct diagnosis based on the ECG can be very difficult. Abnormal depolarization should be followed by abnormal repolarization. Manifesting ST and T changes do not necessarily indicate the acute and ischemia with the LBB pattern. Now for that we have modified Smith and Garbosa criteria for occlusion of in patient with LBB can be created to improve diagnostic accuracy. The most important changes in modification of the rule is excessive discordance in the ST changes. Here you can discordant means there is QRS and opposite we have T areas. It's called discordant. Now in Garbosa criteria there is elevation of the concordant quantum will greater than 1 mm, greater than 5 mm in discordant list, which should be greater than 25% of the S wave, and concordant ST depression in V1 to V3 greater than 1 mm should be positive, can be said is positive for Smith-Darbosa criteria. The original Darbosa criteria, concordant acceleration greater than 1 mm leads with positive QRS complex is scored 5, concordant ST depression greater than 1 mm, and V1 to V3 scored 3, and excessively discordant ST elevation greater than 5 mm in leads with the negative QRS complex scored 2. These criteria are specific but not sensitive for the myocardial infarction. If the total score is greater than 3, it is reported to have specificity of 90% for diagnosing myocardial infarction. Now the modified Smith-Darbosa criteria set the concordant ST elevation in greater than 1 mm in greater than 1 leads. Any leads can be set in this limit. Concordant ST depression greater than 1 mm in greater than 1 lead of V1 to V3. Proportional excessive discordance means in the discordant leads greater than 1 lead anywhere in the with greater than 1 mm ST elevation described greater than 25% of depth of the preceding S wave. So here we can see there is ST elevation greater than 1 mm in normal equipment, which is STEMI. This is normal LVD, and this is concordant ST depression greater than 1 mm, and excessive discordant with STT ratio. This is S wave greater than 25% of the elevation. You can see greater than 1 mm. See, this is here you can see there is elevation in the AVM lead. What are the other causes? There are other causes like aortic stenosis, ischemic heart disease, hypertension, dilated cardiomyopathy, anterior hyperkalemia, digoxin toxicity. We can see this LVP type of syndrome. Next is Whelan syndrome. Now Whelan syndrome is a clinical syndrome characterized by biphasic and deeply inverted T waves in V2 to V3 plus history of recent chest pain which has now been relieved. It is highly specific for critical LAD stenosis. The pattern is usually present in pain-free state. It may be obscured during the episode of ischemic chest pain when there is pseudo-normalization of the T wave in V2 to V3. Whelan syndrome is key example of why all patients should be treated with chest pain must be have serious ECG. Clinical significance of this patient may be framed at the time of presentation when ECG taken and have normal ECG with minimal elevated cardiac biomarkers. However, there is extremely high risk of extensive anterior wall MI in the subsequent days to weeks. Due to critical LAD stenosis, these patients usually require invasive therapy, and due to poorly medical management of this patient, they may suffer extensive myocardial infarction or cardiac arrest if inappropriately treated. For the diagnosis of this patient, there is deeply inverted or biphasic T waves in V2 to V3, which may extend up to V6 chest beats. ECG pattern present in at the time of present pain-free state. Isoelectric or minimally ST segment elevation can are less than 1 mm. No precordial Q waves, reserved precordial RA progression, recent history of angina, and normal or slightly elevated cardiac biomarkers. There are two patterns of T wave abnormalities which can be seen in Whelan's pattern. In type A, there is biphasic T wave with initial positive and terminal negative, can be seen in 25% of the patient. Type B, deeply and symmetrically inverted, which can be seen in 75% patients. Here we can see type A pattern, positive with T biphasic T wave, terminally T wave inversion. Here there are deep inverted T wave, which is symmetric T wave inversion, is type B type of pattern. Now we can how this changes develop. So following the sequence of event which is thought to occur in patient with Whelan syndrome, a sudden complete occlusion of LAD causes transient LPR or MI, causing chest pain and diaphoresis. This stage may not be successfully captured on the ECG. The reperfusion of this LED lesion due to spontaneous throat lysis or pre-hospital expression lead to resolution of chest pain associated with ST elevation improves and T wave become biphasic or inverted. The T wave morphology is identical to patient who reperfused after successful PCA. If the artery remains open, the T wave evolves over time and from biphasic to deeply inverted T waves. The coronary perfusion is unstable. However, the LED can reocclude any time. If this happens, the first sign of the ECG with the patient presented with chest pain, there is apparent normalization of T waves, which is biphasic or inverted. So it is called pseudo-normalization pattern. The T waves switch from biphasic or inverted to upright and prominent. This sign of hyperactive STEMI this is sign of hyperactive STEMI and is usually accompanied by recurrent chest pain, although ECG changes can precede the symptoms. If the artery remains occluded, the patient now develops evolving anterior STEMI. Alternatively, a stuttering pattern may develop with intermittent reperfusion and reocclusion of the LED. This would manifest alternative ECG demonstrating valence pattern and pseudo-normalization or STEMI patterns. This sequence of events is not limited to anterior leads. Similar changes can be seen in inferior leads or RCO or circumflex occlusion. Now, what are the valence mimics? There are both cardiac and non-cardiac causes for T wave inversion. Like it can also be seen in PE, toxicology, patients like marijuana or cocaine use. Also can be staphylococcal cardiomyopathy as well as hypertension. Next is D winter T waves. Now, what are the D winter T waves? A D winter T wave is a ECG pattern is anterior STEMI equivalence. They present without obvious ST segment elevation. These patients are suffering from occlusion of myocardial infarction and require immediate reperfusion therapy. For the diagnostic criteria, tall, prominent, symmetric T wave in the precordialis, upsloping ST segment depression greater than 1 mm at the J point in precordialis. Absence of any ST elevation in precordialis, reciprocal ST segment elevation around 0.5 to 1 mm in area. Typical STEMI morphology may precede the following division pattern. Here we can see there is ST depression with upsloping and prominent and symmetric T waves which are greater than R wave. In posterior MI we can see same pattern, but the T wave are not tall as this.
How can you differentiate it from hyperkalemia where you find cold T?
We in one patient we have to do the electrolytes due to abnormal ST.
Only
ECG. How we can in hyperkalemia there is ST
the
depression.
cold T will come, you think of hyperkalemia.
Here symmetric ampular wave, narrow base and tall hyperkalemia.
And ST depression are to evidence.
ST depression usually
Yes.
तो देखा है आप टिपिकली देखा है टिपिकली देखा है आपका इसीलिए देर ये अंदाज ना आवे क्या हाइपरकेलेमिया से कि
STEMI equivalent.
Yes.
आप बुक पिक्चर के लिए ठीक किरण भाई आप तो बुक पिक्चर
Yes.
Clinical significance of D winter T waves. The D winter pattern is seen in approximately 2% of the acute LED occlusion is often under-recognized by clinicians or also cardiologists. Key diagnostic feature include ST depression and peak T wave in the precordialis. Unfamiliarity with this high-risk ECG pattern may lead to delay in appropriate treatment and with attendant negative effects on the morbidity and mortality. Now next is the hyperactive T waves. Hyperactive T waves are greater than 2 T waves in greater than 2 contiguous days may be the first sign of developing infarct, often preceding any ST elevation. Hyperactive T waves appear broad-based, often asymmetric with more gradual upstroke than downstroke and tall relative to associated QRS complex. Any upright T wave in V1 greater than V6 describe a loss of precordial T wave balance, which is considered hyperactive and considered for ischemia, especially if there is a new ECG finding in this patient. Early after the onset of coronary occlusion and the transmural infarction and tend to be short-lived structure that evolves rapidly into ST segment elevation. Hyperactive T waves have never been formally defined. Look for excessive large T wave relative to the size of preceding QRS complex. Here voltage matters, the voltage is very high, wide, broad and large relative to QRS. Look for changes the size of T wave symptoms. A new upright T wave visible in absence of LDP or LDH is abnormal and mere impression is STEMI. An upright T wave visible is also even as often associated with left circumflexities. These findings warrant close observation and a serial ECG and ruling out hyperkalemia as the cause of the ECG changes.
These changes we can get in non-ischemic or non-cardiac pain. Severe same type of hyperactivity.
We must rule out the chest pain. Any chest pain we have to be able to. Here you can see there are prominent T wave, upright T wave in which are greater than preceding QRS complex. These are the hyperactive T waves. We must rule out.
Here is a cold tented, not in a narrow case. Narrow. If you look at this ECG, you cannot say you have to rule out that.
Hyperkalemia. Yes.
This is tall, tented and narrow case.
Yes. Those are wide cases.
Only thing the lead 3, you look at the lead 3 and AVR,
Yeah.
which shows the evidence of the reciprocal tendency. If you
before 5-6 there is ST depression.
Yeah.
ECG to 5-15 मिनट में repeat करने. There is all chances के classical ST elevation आ गई है.
Yes. So here we for normal pattern in ECG in patient with acute coronary artery. This is a normal ECG. In if we do not produce the patient is the hyperactivity, you can see broad base. Here is a broad base with ST minor ST elevation. If this patient reperfused, we can see the biphasic T wave pattern which we suggest in valence pattern type of pattern, and this is a D winter type of pattern. If patient with this type of ECG reperfused, then we get valence type of pattern we can see. If these patients are not treated, we can see ST elevation in 0 to 12 hours, Q waves with developing Q waves over 1 to 12 hours, and then ST elevation in T wave inversion which we develop over 2 to 5 days, and then normalize of T wave recovery with develops of weak shortcuts, and if there is a LV embolism, we can see persistent elevation with deep Q